Hello, everyone, and welcome to the August ICAP Grand Rounds. I'm Elaine Abrams, Senior Director for Research at ICAP, and really delighted to host this Grand Rounds in honor and recognition of International Youth Day. The Grand Rounds seminar series will present two wonderful speakers and change makers on HIV, and beyond, how research can protect youth in a rapidly changing world. Before I introduce the speakers, just want to remind everyone to please use the Q&A box at the end of the talk. We will take questions, and also that this presentation is being recorded and will be posted along with the other ICAP Grand Rounds series on the website. So now let me take a moment to introduce our two fantastic speakers. Lucie Cluver is a professor at Oxford University and at the University of Cape Town. She works closely with a superb team of partners and students. Together, they collaborate with South Africa government, UNICEF, the World Food Program, UNAIDS, PEPFAR, CDC, IAS, World Health Organization, and countless other global organizations to provide evidence that can improve the lives of children and adolescents in sub-Saharan Africa. Professor Cluver co-leads the COVID-19 Emergency Child Abuse Prevention Response, which has reached over 210 million people in 198 countries with parenting support during the pandemic. We're going to have a bit of a tag team today, and Elona Toska will also share the presentation. She's an associate professor and an adolescent health researcher at the Center for Social Science Research at the University of Cape Town and a research associate at University of Oxford. Her research focuses on identifying ways to support adolescents and young parents to have safe and healthy relationships with people in their lives, their children, partners, caregivers, teachers, and healthcare providers. She also works closely with the colleagues at UNICEF, UNFPA, UNAIDS, the Global Fund, USAID, PEPFAR, and multiple government partners in Cameroon, Eswatini, Kenya, Lesotho, Mozambique, South Africa, Zambia, and Zimbabwe. I'm really delighted to introduce the two of you. Now I'll turn the presentation over to you. Thank you very much.
Thank you so much, Elaine. And I'm just going to share my presentation, our presentation. And here we go. Let's go and check that we can see that all right. Elona, give me a shout if it all looks good.
Looks good.
Fabulous. Well, thank you so much for inviting Elona and myself. And before we start, I just want to share, in 2007, at the end of my PhD, I came to New York, sort of overwhelmed with excitement to get to learn from Claude Mellons, from Elaine Abrams, from these kind of, these kind of great figures in HIV research. And I remember going to a Grand Rounds at Columbia and thinking that this was a kind of research that I'd never really grasped before. It was the idea that we could look into the future and try and predict what research needed to be done. And that time at Columbia has really impacted Elona and my work as we've tried to think about how do we bring that kind of thinking into our work in sub-Saharan Africa. So we're really delighted to be back a mere 15 years later to come and have this discussion and thinking with you. And we will be tag teaming, so you'll see both of us, but Elona and I look very similar, so you may not notice as we switch between. But really just a brief introduction. Our work has been really trying to focus on that bridge between evidence and policy and programming, and to think very specifically about how do we provide evidence that specifically helps national governments to achieve the Sustainable Development Goals for young people at scale. And that means sometimes thinking about research a bit differently, thinking about effectiveness, but also cost effectiveness, feasibility, integration into existing systems. And Elona has really spearheaded the work on active engagement of young people into the evidence development, but also into policy. And everything that you see us talk about today has been discussed and thought about together with our adolescent advisory groups. But we really wanted to start by thinking about the way that we do research, the way that we are, the way that is the kind of best way for our careers, and how that may differ, and how we may start to need to think about things differently in relation to the challenges that the world faces. So this picture is a kind of example of your kind of ideal piece of work. You know, you do a precision study, you know, a perfect randomized control trial where you're aiming to impact an outcome like HIV infections amongst adolescents. And you drive in with a focused, targeted and clear intervention. You test that intervention and you look in the most specified way possible at those outcome, or that single outcome or small cluster of outcomes like, you know, HIV infection, transactional sex, sexual violence that you want to achieve. And then you publish it in the best journal that you possibly can. But when we look at the reality, it looks very different to that. And this is some work that Elona and Patina and colleagues have led working with the Global Fund. But looking at what is the route to HIV risk amongst adolescent girls and young women? And this is a sort of combination of multiple literature reviews. And what we see is this, and similar kind of stuff came out with adults when we were looking at the work of Strive, for example, led by London School of Hygiene, Charlotte Watts and Laurie Heisel and team a few years ago. But what we see is this incredibly complicated set of things that go wrong in someone's life and how they link on to the services that they're receiving, the systems that they live in, the families, the communities, and how those lead on to challenges in the decisions that they are able to make and their eventual HIV risk. And we also have to think about what the world is looking like. We know that there are real, strong and maintaining risks in the area of HIV. For example, we've got between 30 and 50% of viral load, lacking viral load suppression amongst adolescents. We've got continuing very high rates of infections, particularly amongst adolescent girls and young women in sub-Saharan Africa. And we've got very high rates of growing numbers of adolescents. I have to say, since we put that number in, I've rechecked that data, and it's actually too high. But it's still a very large number of growing adolescent population, reaching an estimated 500 million in the next 15 years, and that suggests that we're going to see yet higher rates of HIV risk. But those risks are taking place in a changing world. And as the HIV risks change, the world does not remain static. We're seeing increased rates of climate crisis. We're seeing predictions by WHO of more zoonotic diseases like COVID-19, with a sort of unpredictable epidemics and pandemics, and we're seeing rising rates of conflict. And in sub-Saharan Africa, where Elona and I work, there's particular concerns about geopolitical interference in national governments and conflicts. We're also seeing changing responses. And I think this is something in the HIV world that we need to be really alert to and really think about. Because this is an example, this was very recent, this month. We're seeing a movement from PEPFAR as a completely standalone program to thinking about it alongside and within other global health threats. And I think that thinking has come as COVID has kind of taken the world by storm, and thought about how do we need to think about HIV within a set of other pandemics and risks. And if the world is going to be thinking about that differently, how do we need to adapt and think about the research that we do? And so one of the ways that we have started to think about this has been in the sense of this UN concept of development accelerators. And this was created as an idea in around 2015, 2016 by UN Development Group, in thinking about how do we address this massive challenge of the multiple needs of adolescents and humankind with the Sustainable Development Goals. And really what they are seeing is the need for not just these single outcome interventions, but interventions, services, and policies that have multiple impacts at the same time. Things that can improve education and health and improve work, improve different kinds of health, sexual and reproductive health, violence reduction. And this actually really strongly reflects the conversations that Elona and I have had over the years with policymakers. And you'll see a picture, some of you may know Jürgen Pillay, who was at that time the Deputy Director General of Health in South Africa. And Jürgen, Elona and I sat with Jürgen in Durban one day, and he looked at us and he said, academics come to me and they each come with their separate little interventions. But what we need at the Department of Health is bang for buck. We need things that will have as many impacts as possible and will be as cost effective as possible. And so over the past 5 years, we've been working together and with a whole team of fantastic early career and senior researchers at 11 universities in sub-Saharan Africa to understand what are these development accelerators? Do they even exist? And what might those services be that can have these multiple impacts? This was the first one that we found. It was from a 3-year study of adolescents, 1,000 adolescents living with HIV in South Africa, which Elona has led. And we looked at a set of, this is a big multi-level model, but we looked at a set of 14 possible interventions and found that the most, if narrowed down to those which had 2 or more impacts across Sustainable Development Goals. What we found was that an adolescent who had a combination of good parenting support, particularly parental monitoring, a government cash transfer, and a school where they were not beaten by a teacher or another pupil, had a whole range of positive impacts. We see improvements in having no violence in the home, a 50% improvement in that, a 33% improvement in mental health, a 22% improvement in HIV care retention. We also see improvements in education outcomes, school progression, reductions in high-risk sex and violence, victimization and perpetration. Some really interesting work by Lorraine Scher and colleagues has looked at how many of these development accelerators do we need to have an impact. And this was surprising to all of us because we'd expected that you'd see a kind of linear relationship, that as the more kind of these multi-impact services you get, the better teenagers do. What they found instead was that you get a sharp increase from 0 to 1, another increase from 1 to 2, a much smaller increase from 2 to 3, and then the results plateau out, suggesting that that quite lean packages of 2 to 3 interventions might be really effective. We may not need to be doing very complex packages. We've also been looking, and again, this has been led by a set of, Elona, were you doing this bit or was it me? I'm going to carry on unless you.
It's you, Lucie. I'm taking over at number 3.
Well, the reason I'm laughing is because Elona's again been leading this work, but this has been with a set of fantastic early career researchers across Africa and have been looking at the violence against children studies. And what's really exciting about these is that they, for the first time in about 2018, the VAC studies introduced questions not only about experience of violence, but also about access to the kind of protective services that we think might be helping. And so in Lesotho, with around 7,000 girls, we see that access to food, enough to eat, positive gender norms, and good parenting result in a whole set of positive outcomes across HIV outcomes like inconsistent condom use, violence outcomes like child marriage, transactional sex, sexual violence, and mental health and school retention. So, of course, this is only cross-sectional. The VACs are cross-sectional. But when you've only got cross-sectional data, albeit nationally representative cross-sectional data, you look for patterns. And so we started to look not just at one country, but at other countries. If we look at Kenya, we see again food security, positive gender norms, and good parenting, predicting a set of positive outcomes. If we look at Namibia, we see the same set of predictors with a whole range of reductions in risks, very closely mirroring others that we've seen. And finally, when we look at Zimbabwe, we see these same set of predictors. These are all multi-level models controlling for multiple cofactors. And so we're seeing these very consistent patterns. And when we look at multiple studies across the region, that's including both ours, but also studies by the World Bank, studies by other colleagues, some at Columbia University, we see these kind of patterns starting to emerge. This is not a systematic review, but rather what's coming out from around 30 studies. We often see some kind of cash or income or food or economic strengthening as a very consistent part of the package. And then we see that combined with one or two of these other services that just seem to be coming up over and over again. Parenting support, adolescent-friendly health services, some kind of peer support or mental health support, and some kind of school-based or CSE-related intervention. Over to you, Elona.
Thank you, Lucie, and thanks for driving the slides. And I hope everyone can hear me okay. I did mention to the ICAP hosts that apparently the cable connecting the internet cable has been damaged. So if anyone is having connectivity issues, you can turn off incoming video. I may do that too. The next question that emerges, and that I think many of us are grappling with following the patterns and those clusters and combinations of impact or impactful interventions, is around how do we bring them to life. So it was great to see names of some colleagues in the attendees list that we've had many of these conversations with Delivet and her team and some of the FIA colleagues, because these require thinking across different sectors and data sets. And we've been working closely with the Global Fund, which is a big driver of how funding on HIV is decided and spent in several countries, particularly with regards to adolescent girls and young women. In 5 specific countries, we've been thinking around how do we bring this idea of multi-sectoral interventions to life, but in the context of really limited and dwindling financial resources. So one of the ways that we have done this is to think around HIV-specific interventions that the Global Fund already is funding and how to refine them, but also how to bring together this idea of parenting programs, cash transfers in an evidence-driven way, and that matches what is happening in each country. So in the next slide, we started by mapping out the approach that we did this through, and we combined existing national guidelines. Many of you do this combination of policy reviews with evidence reviews, and we had to do often a colleague reminds me, you could do 20 systematic reviews with some of the reviews that we were trying to do. So we really adjusted our methodologies to think around very rapid reviews around these multiple interventions, which are not actually always defined in the same way. And what we're trying to do is think around targeting. So who needs an intervention most, and then what and how this intervention should be combined and delivered. In the next 2 slides, it's just some preliminary summary of how we're thinking around bringing together the analysis to date that Lucie has shared around, not one-to-one, but many-to-many, so many inputs, many outcomes with the Global Fund work. And you'll see on the left here, the definitions of these inputs changes, but the HIV-centered work that many colleagues are driving and working on thinks primarily around biomedical solutions. So how are my condoms being used? How is HIV testing kits, the kits, but also the process, how are they delivered and reaching those intended? How is ART-based prevention and treatment, so PrEP, PEP, and large-scale treatment programs, how are they reaching everyone? And what we've been trying to map is how these are now linked when delivered individually or in combination, not just with the first column, primary HIV-related outcomes like incidence, if we have it, or STIs, prevalence when we don't have, or HIV risk, but also with other categories. So violence-related outcomes, behaviors that are linked to HIV, but also sexual and reproductive health more broadly, mental health and well-being, and educational outcomes and economic outcomes. Because many young people do not wake up in the morning thinking about PrEP, but they will wake up thinking about being hungry or not having a job. And really what's emerging out of this is a really intense focus on how do we bring components together to improve the effective use of these core HIV-centered interventions. So how do we make PrEP effective? So this has taken us to dig a little bit deeper into, for example, economic and livelihood strengthening. Colleagues in country know that they want to address the structural drivers that affect young people's lives via hunger, reduced access to schooling and other services, pushing them to migrate or into high-risk relationships. So we've been looking at intervention types, and this maps out the evidence to date on the different types of interventions and different types of outcomes. What we're doing next, and this is work led by colleagues at UCT, mentored by Dr. Rachel Yates at Oxford, is thinking about how do we give a bit more texture to the findings and look at the strength across different types of interventions. And a lot of these conversations are happening in parallel with reviewing and informing Global Fund country applications for funding. And one of the questions that comes up is how do you take a lot of these evidence-based interventions and findings into the design and delivery of packages? So I wanted to share this conceptual framework that was adapted by one of our colleagues at Oxford, Madison Little, when he was doing a review of cash transfers for children outcomes. And it was really powerful because we often say it'd be great to do to have cash transfers delivered in the country. But what is already happening in the space really makes a difference as to how a cash transfer can be layered onto existing programs or introduced to a new subgroup or subpopulation or completely designed from scratch. So I thought many of you here are involved in testing and designing combination programs that have a cash component, but one could actually change the anchor. The anchor in this example could, for example, be HIV testing. So what's interesting is to think around how do we then evaluate that these models are actually working. And it's really where some of the more implementation science and novel methods that I know you are all thinking about can come into play. We've been then working specifically about into thinking, well, packages are really important, and what combinations work is great, but we may also have to think what combinations work best for certain groups. Our, and not only our team's analysis, but there's been an increasing focus in the next slide on adolescent girls and young women who've already initiated motherhood. And this is a very particular group of young women. They already are experiencing adolescence, which we know is a time of immense innovation and creativity, but also really deep vulnerability that can stem from early childhood adversity, but also during the second decade of life. HIV risk or living with HIV adds another layer, not only because of the physical illness, but also the psychosocial and emotional and mental health elements of living with HIV or being at risk of HIV and worrying about HIV. And then The third element that comes in is pregnancy and breastfeeding and early motherhood, which is also a big physical change, but also a transition in terms of socio-emotional terms. And when these three co-occur, whether two or three of them together, it's really an important, it's really a difficult time. So we've been thinking, how do we support adolescent mothers? And the data, there is actually strong quantitative data that HIV status, so living with HIV and motherhood co-occur in several countries. This is some data from the Lesotho Violence Against Children survey, some analysis led by two of our postdoctoral research fellows. Those of you who may be based in West Africa may encounter our colleague Bolade working with UNFPA in the coming years. And what we see here are percent probabilities of reporting these 5 different outcomes. This is cross-sectional data, so as much as possible, we try to avoid reverse causality of factors. This is adjusted for age, district, and a few other factors. But what we see is that adolescent mothers in the big dark circles are much more likely to report inconsistent condom use, multiple sexual partners, age-disparate sex, inequitable sexual partnerships than adolescent girls and young women who have not yet initiated childbearing. And because we don't want to blame all of the behaviors, we actually created a composite measure. Sorry, Lucie, in the prior slide, just a composite measure that is not just any sexual risk, because adolescence is a time where a lot of change is happening and relationships do not always stick or remain the same. And looked at condomless sex in the context of any high-risk sexual relationships, and the difference really remains 40% compared to 8% in the right-hand side circles. In the next slide, we'll try to understand how adolescent motherhood and HIV may interact beyond sexual risk, as defined in our public health spheres. And this is some advanced analysis that Bolade did try to tease out quantitatively the syndemic effect of HIV and motherhood. And in terms of education, we really see that adolescent mothers living with HIV are really doing much worse in terms of school enrollment. They have much higher rates of school non-enrollment than those mothers who are not living with HIV or those who are not mothers living with HIV. And this is a 53% of the non-enrollment in school was attributed to the interaction of HIV and motherhood. So it's important for us to think, how do we address this group where these vulnerabilities co-occur? In the next slide, Lucie and Will, our colleague William Rutgerd at Oxford, have been working with the World Food Programme to try and then think, how do we interrupt these vulnerabilities and how do we address these endemics? Amongst adolescent mothers who had enough food to eat in the last week, we modeled a reduction in transactional sex when compared to those who did not have enough food to eat. So we didn't give food. This was just documenting what young mothers had access to. Age-disparate sex from 27% to 20%, not being a NEET, which many of us in the social sciences, or at least in South Africa, we use, so not being in education, employment, or training, with food security, 50% down to 39% being livelihood when there was not enough food, and similar reductions in sex and substances and alcohol use. We didn't observe reductions in all the outcomes that we tested. So then Lucie and our colleague Janina Joachim, together with a participatory research team co-led by Dr. Hlakoma Mankalaza and Chelsea Coakley, who are pictured all in the screen here, started thinking about what does one add to food security. And this is analysis that's quite complex, all complicated questions to Lucie, or we can try, Lucie, to handle these. Janina can address them by email if needed. But what we're trying to model here is the concurrent effect of young mothers having enough food to eat, these squares on the left, having access to formal childcare support, because we all know that being a parent is a really difficult job and we all need help, safe parenting, so them themselves having a strong and safe relationship with a caregiver and a parent at home, and being treated well in facilities. And seeing how the combination of these 4 components maps onto clusters of outcomes: mental health, HIV risks, violence, and their future aspirations in education. And with preliminary results show that these four are associated very strongly, and this is longitudinal analysis with data pre and post-COVID, with improvements in some outcomes in all of these four domains. And we're now trying to tease out which combinations may be most impactful for different outcomes. In the next slide, I think I hand over to you soon, Lucie, after this section, we just wanted to do a bit of a deeper dive on adolescents living with HIV. So we've talked about adolescent mothers, and we know that those living with HIV may do particularly worse. Lucie mentioned low rates of adherence in adolescents and young people living with HIV that we've documented and many colleagues here have worked on. And what we've started looking at is mapping out the different packages. So many of you may know of the work of Jeanne Deary, based on the Friendship Bench, which not only improved viral load, but also mental health in Zimbabwe. So those who received the Jeanne Deary intervention were much more likely to see improvements in at least two of these outcomes. There is actually emerging data, which is not published and it's not yet an RCT, from their Young Mothers program, showing that there is a lot of improvements in both viral suppression amongst young mothers, but also early detection rates for the children of young mothers when the Jeanne Deary Young Mentor Moms model is applied. In the next slide, we then started to think, and this is informing some of the more multi-sectoral approach that colleagues at PEPFAR and others are thinking about. Our colleagues Sia and Will and Lucie have been looking at this cohort of adolescents and young people living in South Africa that we've followed up on since 2013. And about 1,000 of them, 933, were able to interview over time, over 85% of our initial baseline. Those who accessed psychosocial support and economic support in the form of consistent access to the child support grant, individually and in combination, were much more likely to have lower rates of viral load, over 1,000 copies per milliliter. The child support grant is a government program in South Africa. So here we're just comparing those who had access to it versus those who didn't. But the psychosocial element can be support at home or peer-based models. Those support groups, which we know have good effects, were really not available in the Eastern Cape, where our team works with these young people. In the next slide, we tried to think, what else can we do to support? And one of the areas that often comes up is what can we do in facilities? Although WHO has a really wonderful definition of adolescent and youth-friendly services, it often ends up being a long checklist. You know, in the South African context, when it's nationalized, I don't know if this is true in some of the countries that colleagues I can see amongst attendees work, but one of the criteria for adolescent and youth-friendly services is whether the policy is printed and available at the clinic. But this isn't the same as being treated respectfully by a provider or getting all the answers that you need. So what we did in this analysis, together with Sia and some qualitative work by our colleague Uma, is to look at different dimensions of clinic experiences. And we tested about 7 of them: time to get to the facility, waiting time to see a provider, was it safe and affordable to get there, were they treated respectfully and kindly by the staff? And this was a low bar. It was really not feeling shouted at. And what we were able to see is that there were actually those young people out of these 7 different dimensions, and this was particularly adolescent girls and young women living with HIV, nearly 800 of them, those who had access to safe and affordable clinics and those who were felt treated respectfully and kindly by the staff were much more likely to experience improved viral suppression, better clinic attendance, reduced TB symptomology, lower rates of treatment interruptions, and better self-reported adherence to antiretrovirals. And you'll see on the right the improvements from the differences. So in the case of viral suppression, it improved from 61% to 77%. So we still have work to do beyond the facility, but just these 2 key ingredients were critical to improving the chances of survival in this group. And you'll see what a young woman living with HIV shared with our colleague Uma. Often it is about preemptively being worried about being shouted at. So even if you may not be shouted at, it just holds the young people from actually going to facilities. So we're thinking about how to make this happen at scale next. And I think it's over to you, Lucie.
It is. And as you were talking, Elona, I was reminded that this study itself was inspired by the work done at Columbia University with adolescents living with HIV, and really seeing the work and the care that had been done and the research that had been done with them, and thinking how important that was going to be for South Africa. So we really did just want to end with some thoughts, and this is not the kind of conclusive evidence at all. It's really trying to grapple with some of these challenges of how do we think about delivering these kinds of programs that we're finding to be effective at scale. And you know, I think that this is often a kind of chasm between research and policy, that research produces these effective but perhaps high intensity interventions, and what policymakers need is often something quite different. They need to think about multiple outcomes. They need to try and think creatively beyond in-person intensive programs. They're concerned about the limited reach of current delivery models that we often have. And they're trying to think constantly, how do we maintain impact or increase impact at massive scale, not at the scale of hundreds of thousands, but at the scale of tens of millions, with shrinking resources, with limited fiscal budgets, and potentially reducing aid budgets. And so some thinking that we've been trying to be doing in the area of parenting is really just to talk about as a springboard for thinking more broadly. There's been some amazing work in the US on digital delivery of interventions, but we've been trying to think, is this possible in contexts like Tanzania, where you've only got about 30% smartphone access right now, but predicted to go up to about 80% within the next 2 years. This is the transferal of the WHO UNICEF Parenting for Lifelong Health program into an offline app-based format, open source, for low-cost smartphones. And I think this is an interesting example, because you'll see on the right the Prime Minister of Tanzania announcing that this was going to be the new national program in Tanzania. This is while the randomized control trials are still underway. And I think what it demonstrates is the need and desire for scalable interventions. Now, we've got only some initial evidence. This is just pre-post pilot for this. But one interesting thing is that we're already starting to see some potential benefits of incorporating programs within programs and linking programs. And this is the one thing that I wanted to raise for us to think about. And Elona and I and Jamie Luckman have been talking with colleagues at PEPFAR and at UNICEF about this. But we often come to our interventions thinking of them as kind of our unique intervention. You know, as academics, we create something or we test something and we test its impacts and we say, this is our, like, here's our orange, this is what we need to deliver. And this very much mirrors what happens in international development. You know, different NGOs will have their different packages or different interventions. But actually, when you think about the experience of the service user and the experience of a government who's trying to deliver things, that may not be the most efficient way of reaching people and the most effective way of reaching people with their multiple needs. And interestingly, when you look at the private sector, we're actually seeing this massive movement of what is sometimes called co-opetition, where different private companies are linking together to meet service users' needs or to sell them more things. But it has made us think about whether we could think about developing much more open source approaches to our interventions and delivering, for example, modular delivery of different interventions. We wrote to Parenting for Lifelong Health, wrote to No Means No and said, would you share your content? And they openly shared it. So did Let's Talk, which is a PEPFAR delivered program. And to think, can we move beyond some of the traditional boundaries of science, but also the traditional boundaries of service delivery, to think about what can we do that will be the cheapest, most effective, and most scalable interventions that will be the easiest for our service users and their families to receive. And so Elona and I really just wanted to end with some big questions. The new UN Development Report 2022, a difficult read, but an important one, starts with a statement by the head of the UNDP, which says that we are now living in uncertain times. And every time you open the paper, that is clearly and manifestly true. And so we ask this of ourselves as researchers: how will we respond to these uncertain times? How will we need to keep doing the same things, but also think about what needs to be done differently to be ready for the challenges that young people are going to be facing over the next decade? I'd like to say a huge thanks to our funders, and we're looking forward to questions.
Wow. Well, thank you both so much for that sort of deep dive and highly provocative talk. It was really fantastic. I think we have a couple questions posted, and I'll start with those. And I have a lot of questions of my own. So somebody asked, where do you think digital therapeutics sit? I think you started to address that in the last section, but maybe you'd like to expand on that somewhat.
Gosh, I don't know. Elona, what do you think? I'd love to hear from Dean. I'd love to hear your thoughts on this as well. It's not coming in. We're not seeing it so much. But Elona, what are your thoughts?
Dean, I don't know if you're able to unmute and just clarify exactly what you mean when you say digital therapeutics. There are platforms that support, for example, with counseling and getting through HIV testing in the area, but I think you may mean something different.
You have the prerogative to answer it as you'd like.
As I'd like. All right. I think there is a possibility that we could reach a greater number of young people, particularly because Lucie and I mean, we do different ranges of work, but we overlap in the area of 10 to 24-year-olds and how we support them with high quality information and support via platforms. But we, as Lucie mentioned, that may not be sufficient for everybody. So for hybrid models would still be needed to ensure the effective use of biomedical interventions. I don't know that answers your question, Dean, but you can reach out separately and we can discuss more. Over.
Okay, let's move on. I'm going to pull a question in the chat, which is from Delavet, who thanks you for a fascinating presentation on intersectional risks in youth and the benefits to multiple outcomes. Now, there are several methodological challenges with measuring multiple outcomes that are proximal and distal. Currently, we run separate models for each. I'd like to hear your thoughts about other ways to assess the whole person and whole community.
This is a great question, and it's really something that we've been struggling with. And it's not just, it's a question that holds through observational, but also through randomized control trial outcomes and through our cost effectiveness. And it's this question of how do you there's a sort of methodological question of how do you simultaneously measure multiple outcomes at the same time and account for the fact that those outcomes are not independent of each other. They're interacting with each other. School dropout will increase your risk of transactional sex, for example. Early marriage will increase your risk of school dropout. So we've tried a whole bunch of things over the last 5 years. But I think what we've really landed on and are using mainly now are these multi-level models, which allow us to kind of simultaneously model all of the outcomes at the same time, but account for the interactions between them. What it doesn't do is necessarily show you all of the interactions between them, because when you try and do that in a kind of structural model, you get into it gets very confusing to try and interpret. But that's what we've been using, and we've been putting all the code open source for that. And if you're interested, drop us a line and we'll just link you up with that, because it's, you know, it took us a long time to work out how the hell to do this. And we're really happy to share. But I think what is also really important is also thinking about the cost effectiveness on multiple outcomes. And this has been, again, this was this challenge that Jürgen Pillay, who's now at the Global Fund, charged us with about, was it 7 or 8 years ago, Elona? And we've had a team struggling to work this out for about 4 years now. And 3 colleagues, Hernando, Chris Desmond, and Will Rugard, have worked out how to do something called a discounted cost effectiveness, which essentially allows us to measure cost effectiveness not just on a single outcome, but on multiple simultaneous outcomes. And it radically changes the cost effectiveness of a multi-outcome intervention. And again, we're going to make that all open source. So if it's any use to you, we're really welcome to share it. I think what our models don't do, which you suggested, was this idea of proximal and distal. You know, we kind of treat them all as the same distance from the intervention. And I don't know, gosh, that's the next step, isn't it?
Yeah, so Deli, we've talked a little bit about this together, Delivet, and I look forward to hearing an update on your work, maybe at another Grand Rounds, because we're thinking around how we use, you know, what the data sets can do with regard to this. So one doesn't always have the best, a large enough data set to be able to have power when including community level indicators, as well as you know, the proximal and distal measured at different levels as well. We just have different students testing different ideas, including path models, so quite advanced structural equation models with different data sets. So we have a colleague in one of our doctoral researchers, Silingani Sibuzumbunu. She's using GAGE Ethiopian data on young adolescents and looking at how gender norms at the community level, which is measured at a slightly different level, using mixed models, as Lucie mentioned, may affect aspiration age of early motherhood and aspired age for marriage and motherhood. So just trying to see how some of these factors that may be not sitting at the individual level, like community gender norms and expectations, may trickle into an adolescent's actual outcomes. But it does require a combination, that I'd say iterative combination of theorizing and looking at data and methods. So I don't think it's only at the methods. And perhaps this is where we just need to come together, continue coming together in a multidisciplinary way, because it requires also thinking about the young person and what's happening in their lives, and how the data matches that, and how the methods speak to it and helps us describe it. Over. Great question, Deli.
Fantastic. So I have 2 related questions, and I'll put them together for you. One from Claude Mellons, who also appreciates the fabulous overview and incredible work. She's wondering if you have any thoughts or could talk about how to translate this into other contexts where people don't have such strong relationships with governments, or governments are not focused on these kind of partnerships, and how cash transfers or economic empowerment interventions may be sustained. And another participant is asking how governments have used the data in these studies to prioritize and invest, particularly in mental health for people living with HIV, and your thoughts on how to implement mental health interventions. So, sort of.
Lucie, can I take the first?
Different settings, yeah.
Let me try the first one, and Lucie will add. So thanks, Ndeshi and Claude. These are both really important questions. And I think we all know that one study or one set of analysis, or not even our 65 slides with beautiful diagrams by themselves, will make governments change everything. There's competing priorities in budgeting. What we have realized, and I'll give just 2 quick examples, and Lucie, maybe you will have more to add, is that it's also about finding a common ground and understanding context. So for example, Claude, to speak to your question around cash and economic empowerment. This is still a work in progress, but in the context of Lesotho, and some colleagues here may have heard me give this example before, the government actually has, I think, a nearly $2 billion social welfare scheme. But the funding that came for cash transfers from the HIV stream was about $1 to $2 million. Now, what happens in the case of separate streams and lack of coordination is that often we set up a separate program, you know, with this $2 million. I'm just giving examples. I mean, colleagues in Lesotho can actually, I saw a few colleagues from CDC joining, you can correct me, but what we are advising, and using some of this data, what we're advising colleagues to consider is to think about how can this smaller pot of maybe more HIV and psychosocial kind of support-centered funding can be added on to an existing wonderful program like the Lesotho social welfare that has targeting embedded in it through the NISA system with household vulnerability to add value and reach young people, for example, if that is the focus of it, rather than do a whole separate training program, which may be really wonderful, but can only reach, you know, 2,000 of the 200,000 adolescent girls and young women in Lesotho. So this is just a very concrete example, but one isn't running an RCT on it. So it requires actually really spending time and finding these matches and opportunities and then hoping that they are doable. In the case of mental health, one of the big advocacy points for young people, specifically that Lucie and our colleagues Mona and Rachel and the team have worked on, is to join forces with the WHO's partnership for maternal, neonatal, and child health. Lucie, I'm looking at you in case we use the acronyms a lot, everyone. Acronym soup is the name of the game, PMNCH. And they're holding a global forum for adolescents, you know, in mid-October. And the process of it, in preparing for this 2-day big 1.8 billion young people movement event, we've been working with individual governments. I've been focusing on colleagues and working with colleagues in the South African government to actually come up with, bring together colleagues who are working with adolescents to come up with commitments that are multi-sectoral and think about, you know, not just about poverty and unemployment, which is what the big things are in South African youth policy, but also mental health and violence prevention and HIV risk reduction, and safe pregnancies and motherhood. Over to you, Lucie.
I think these are such fundamental and actually really difficult questions, because I think, you know, as researchers, we work with the policymakers who want to work with us, don't we? And also because we're researchers, we're not like, that's not our whole job. We're kind of juggling it with you know, trying to run the trials and trying to do the research and trying to do our teaching and all of that other stuff. And so sometimes I wonder if we don't try hard enough with the ones who don't want to work with us. You know, and what about the countries where really none of us work, you know, Central African Republic. And so sometimes those are the big regrets, you know, what should we be trying to do that will be maybe really unlikely to work and be successful? And how do you sell that to a funder or a, you know, and how do you sell those kinds of risks that often come with those countries to funders who can't, you know, funders and universities that are somewhat risk averse? You know, I think we're doing some work in Sudan at the moment, and I just keep thinking, is this going to have any luck at all? Probably not. And okay, well, how can I kind of bury that if it doesn't, so that they won't cut off the rest of our money, you know? And so really, honestly, I think fundamentally, Claude, this question's a really hard one. A couple of thoughts. One is that for a lot of governments, mental health is not a priority, and it's not going to be. And so sometimes we have both we can try and have both a dual approach of advocating for its importance, but also identifying interventions that have other impacts that a government does care about. So, for example, impacts like crime reduction. Governments really do care about crime reduction. They often care about education or youth employment. And if we can find interventions that do those as well, we may then have more luck with a government for whom something like mental health or sexual violence is not a priority. The other thought is, I guess, some experience that we had during COVID when we were trying to deliver evidence-based violence against children prevention programming, kind of light touch resource-based programming at a global level. And at that point, many governments in the region were actually not functional. You know, people weren't able to come into work at all. There was no functioning internet. Like, governments were really unable to reach families. And we found some pretty extraordinary things. You know, I've never worked with the faith-based communities before, but there was an extraordinary capacity to reach people with services through a combination of NGOs, faith-based organizations, and UN agencies that did give me some hope that even if there may be more options and more creativity. And then the question is, how do you do that without missing out people? You know, evangelical Christian networks were absolutely phenomenal at reaching people, but they probably weren't reaching Muslim communities in West Africa, for example. And so how do we reconcile those challenges and those opportunities? These are great questions and not easy ones.
Well, I'm only choosing the hard ones. So we're going to have to come to a close, but I'm going to ask you just to spend 2 minutes talking about what you did last week, because you were talking, you mentioned to me that you were in the US, in DC, advocating around PEPFAR reauthorization. And I'm wondering if you could just speak to the importance of that, and to maybe speak to the audience about what they can do or how they could be thinking about this.
Well, colleagues, I guess this is a really crucial and really urgent thing to talk about right now, which is that, as many of you may know, there's a substantial threat to PEPFAR's reauthorization at the moment from people within the US government and from lobbying groups who are trying to prevent PEPFAR's 5-year reauthorization at the moment. The impacts of that, and this is happening right now and is really urgent, it has to be reauthorized by September. And the impacts of loss of PEPFAR reauthorization would be very, very substantial. There's a letter and an editorial coming out in The Lancet on Thursday, which are really pushing for this. But I would just really urge, if there is anyone who has access to anyone in Congress, anyone on the Senate Foreign Relations Committee, or has the opportunity to share your views on this, to share arguments. There's articles in the Washington Post and New York Times about this, but really to share the importance and the success and the absolute essentiality of PEPFAR for HIV services in sub-Saharan Africa. Now is the time, do not wait. It is horrible to think about what would happen if we didn't have that provision. Thanks, Elaine.
Okay. Well, I want to thank you both. This was really fantastic and, as I said, provocative and in the best sort of ways. And I'm sure you'll hear from a lot of participants. I want to tell everybody the webinar recording and slides will be posted on our website. I think everyone is familiar, so you can come back to this and extend the learning. And I just want to invite everyone back in September, where we will hear about healthcare under fire, public health in conflict zones. So thank you, everyone. Thank you, Lucie, Elona. It's been a pleasure.
Thank you for having us.
Thanks all. Thanks, colleagues.